Namaskar, myself Dr. VIPUL GURJAR. I am practicing surgeon in Vadodara and my special interest in anorectal disease, as well as I am a professor and head of the surgery in Sumandip University, Vadodara. Today I am going to discuss my view and my thought about the fistula in ano. Mainly, my discussion is about first is to know about the different terminology, sensitization about the available methodology, and my view regarding the good result I giving a surgery. Okay. So the fistula, I'm not giving that much anatomy importance. Uh, if the patient is coming with a large, small fistula, then the surgery would be the fistulotomy. If patient having a straight medium size fistula, then surgery is still a fistulotomy or the fistulectomy. These two methods are mild to moderate size fistula surgery is a promising surgery to give the 100% result. But the problem or the confusion or the need of different type of surgeries occurs once the patient having a long track fistula. Second, if is it involving a sphincter, yes or no? Is it mature or immature? Then the different type of modality like lift, slough, laser surgery, and tropies. These are the different type of modalities available. So how to deal and what is the best available method? My preference is the fistulectomy over the fistulotomy, because some people are saying that the fistulectomy and fistulotomy is almost giving a good result. But if we see the practical point of view or theoretical point of view, we are leaving a posterior wall in a fistulotomy. So, if possible, why we should leave the posterior wall in a fistulotomy? There is a very small layer of fistula tract is available. If we remove this posterior wall of a fistula, we can close primarily and we can decrease the wound size, and that gives the benefit to the patient for early healing and less pain. So the my preference, whenever the possible, do the fistulectomy over the fistulotomy. Another confusion about the fistulectomy and the coring of fistula. What is coring fistula? In this coring of fistula, we inject the methylene blue through the external opening and identify the internal opening. We are not trying to probe the fistula tract, because if we try to probe the fistula tract, there is a high chance of artificial injury or artificial opening the tract through the tract. So first preference, if you are doing the coring or the fistulectomy, do not try to probe forcefully. If you have some feeling of just to know where track is going, then it's okay, but don't probe forcefully or don't do any probing. In the coring of fistula, we use surrounding uh, the marking of skin cutting of external opening. Then we ligate this external opening with the Alice forceps or the one suture of 20 or 10 suture, and with the guidance of a fistula tract itself, because fistula tract is so much thick in a chronic condition that it may be very easily differentiated from subcu part or the live part of the body tissue, and you can identify surrounding the tissue, and you can use cotrim to remove separate the fistula tract as much as possible. With the help of good assistant and L-shaped retractor, this whole fistula tract can be core out like a tunneling up to the internal opening. And at the internal opening, you may have a two option. One, you ligate the fistula tract at the most nearest part of an internal opening, because this ligation of tract is the only possible once the fistula tract is mature and it holds the suture line. If it is immature and if you have done artificial or you have removed the internal opening proximal to internal sphincter, then you have to cut down the distal sphincter also. That means you have to open the proximal tract, otherwise there will be a fecal contamination in this coring tract. So be careful. If you are doing the coring and if you are removing the internal opening, then you must cut distal part of sphincter. What happens otherwise? See, you have done an artificial opening proximal to that anal verge. Okay, because anal verge is surrounded by the sphincter. The sphincter remains in contracted state in a resting position. Once the patient stool is passing, they may resist due to the sphincter. It may goes in this proximal opening of you have done during the coring, and this stool particles fecal contamination goes towards the your excised area, and that causes fecal divergence and the fistula non-healing fistula, and patient may feel passing of flatus or the stool through this wound. So what to do? I suggested either ligate or remove the distal sphincter fiber, cut the sphincter fiber so it becomes a low pressure zone and stool diversion will not occur. If you are cutting the skin and the sphincter, that is known as a fistulectomy. If you are not cutting the skin and sphincter, then it is known as the coring. During the coring and the fistulectomy, L-shaped retractor and xylocaine adrenaline infiltration before the dissection and node to probing and instill the methylene blue, diluted methylene blue in the tract may helpful to guide. During the dissection, you definitely, if you cut the fistula tract, you will get alarming sign of bluish methylene blue. If you have a multiple branch also, this also may guide you this methylene blue, that you need to excise this extra branching also. Now another thing of the fistula, many patients are coming that after the perianal abscess surgery, Means the patient also give the history that he or she underwent the perineal abscess surgery before 21 days, but still there is a post discharging opening which is 6 to 7 centimeter distal to the perianal. And on the PR examination definitely you will get the internal opening. So you will say this is a fistula, and definitely it is a fistula because internal opening is there, external opening is there, but it is a 6 to 8 centimeter opening, and there is a possibility of a transpintric tract, as well as it is a curvilinear in a position. What is your choice of surgery? I'll not go for the surgery. I'll ask a patient that please wait for few month or few days to make a fistula tract a mature like a pseudocyst of pancreas. If there is an inflammatory process or immature cyst is there, we are not operating, we are not going to operate a pseudopancreatic cyst. After the maturation of cyst, we are going for the surgery. And because while dissection of the fistula tract, you will not find adequate thickened wall to isolate it from the surrounding tissue, and once you are not you removing this whole cryptogland as well as fistula tract, there will be a chances of recurrence. So in an immature tract in asymptomatic patient, I will advise patient to wait as long as possible in a long, complicated, transsphincteric curvilinear fistula. I am not giving this method or advice to small tract fistula. Okay, so whenever this type of complicated fistula you found, better to wait it make a some chronic and thick wall fistula, and during this thick wall fistula you will get a large thickened ball like cryptogland in the intersphincteric region, and after this removal of this intersphincteric gland you will definitely get a very good result, and that prevents the recurrence of the fistula. This is one of the very good uh, principle I learned in my practice, and you must think about this principle to make a fistula mature. In a complicated case, do not hurry to go for the surgery immediately, because many fistula lasting for 6 to 8 years, 10 years, they won't be bother to the patient. But if you do in immature tract, there is a huge possibility for the recurrence of fistula. Now one more technique is emerging, and I believe as well as I am doing is the fistulectomy or the coring of the fistula with the cutting of the sphincter and the primary repair of the sphincter. Yes, this is a very promising surgery to cut or partially cut the sphincter and resuture the sphincter. If internal sphincter, there is a without hesitation you can cut and you can lay open, keep the open the sphincter. But if you have cutting the soft and subcutaneous part of the internal sphincter, there won't be any much problem, and you can get ahead without fear of incontinence. But try to preserve the deep part of the external sphincter. If you touch that internal this deep part of this external sphincter, there is a high chances of partial or some continence problem after the surgery. Nowadays my preferred surgical technique is the fistulectomy, either coring or the fistulectomy with the primary repair of the sphincter whenever it is needed. Whenever I first try not to cut the sphincter, but if it is needed, then I'll do that. After the other problem that because of this large dissection, there will be huge raw area, and because of this fear and non-healing and daily dressing, everything, patients are so much curious about that problem. To overcome, whenever distal part, you try to close as much possible like a sphincter and a subcu portion, but do not close the skin. You try to marsuperize the skin margin. There is a advantage of this superization is the first, it decreases the raw area, it gives a cosmetic, as well as it prevent the premature closure of the fistula. So the marsupialization is to add this marsupialization technique in the fistulectomy or the coring of the fistula, you are getting a very good result. As well as if you are doing a good surgical excision of infected portion, there will be 101 percentage fistula healing. And don't think any wrong thing about the recurrence. But if there is a discharge, that discharge is because of you have not excised properly, or cryptoglands remains inside because of fear of injury of the sphincter, then the recurrence will definitely occur. So the excision or removal of gland and infective foci is the key step in a fistula surgery. So you need to do some daring to remove all the infected portion. Okay. Now another technique which is very keen to learn by the many surgeon is the laser surgeries. Laser surgery alone is not a preferable. There are the lots of recurrence and there are the high recurrence rate if we are using a laser alone for the fistula surgery. That means you need to add another technique to laser surgery. What are the advantages and what to do in a laser surgery? There are different modalities. You can add a lift ligation of fistula tract in the intersphinctic region, slope subcutaneous ligation of a tract, which is given this invented by the Dr. D.U. Pathak sir from the MP India. This is like a slough technique. Or third technique is the excision of proximal portion of fistula tract, including internal opening and cryptogland up to the intersphinctic region. Means you have to excise the internal opening, fistula tract up to the intersphinctic region, then deal in all these three conditions, deal distal portion of the tract with your laser. Now, how to do this laser? Once you deal with your proximal portion like a slough, lift or the proximal excision, you use 1470 diode laser. You must use a radial fiber. You keep machine at 10 to 12 watt machine, a 10 watt joule. You need a small scoop or the brush while doing the laser surgery of fistula. How to do this first? You do not require any handpiece to enter the fistula tract. You first apply the ice over where you want to apply the energy, then pass a radial fiber slowly up to the intersphincteric region where your distal tract is available. Then start the machine and withdraw the fiber 1 second 1 millimeter. You withdraw. During this withdrawal, you move the fiber like this. Because of this energy and tissue destruction, carbonization will occur and that stuck the tip inside the fistula tract. And during this removal, if it is stuck, you have to pull. Sometimes you miss that tip inside. So slight movement is continuous while the withdrawing. After giving this all the track, you need to scoop, hard scoop through the track in which you have given the energy. Why? This laser energy is damaging the internal epithelium of this tract. This internal epithelium is damaged and like a necrotic slough, and use the scoop to remove this all the debris removed from the tract. Then give saline wash. Further, you can apply this laser fiber, and while this second time removal of this laser fiber gives slight external pressure slowly beyond the tip. This may help to obliterate the cavity. Mind well, laser itself alone is not obliterating or injuring or destroying the full tract. It obliterates partially, it will not obliterate complete. But our mechanical scooping very important to scrape out all the epithelium, infected epithelium, and that may increase the cavity obliteration of fistula tract. If there is no infection, the cavity will collapse and gives the good result. After this day, you have to enlarge the external opening so all the discharge may come out very easily. After that, there is no need immediately for the saline wash. Just give the saline cleaning outer side, because this required some obliteration of tract required some time. Okay, so this is how we do the laser surgery. In my practice, I am not doing that much laser in compared to fistulectomy and the coring of the fistula. If patient is willing and patient is explained and patient is ready for the some part of recurrence, I am doing with the proximal excision and ligation of tract and distal ablation with the laser surgery. This is my preferred choice. If you want to know the slope or the lift surgery, you can give me in the call or you can message me. I will discuss personally. At present, I am not doing that discussion because the video will be very long and it will not like you. So I have explained what we are doing, I am doing, and what is more practical important. So thank you very much. You can go through my YouTube channel. There are such a many videos and surgical step for different type of anorectal surgery, and you can message me also on my WhatsApp number or this on YouTube comment also. I will try to clear your questions. Thank you very much. Bye.